Okay, so the goal of this presentation is to talk about controlling bacteria through operative and excisional debridement. I don't want people to get distracted thinking I'm trying to put one or the other as being superior. So we've all seen wounds like this, and when we discuss debridement, our goal is to take this wound and make it look something like this, with nice, healthy edges, good granulation tissue. Typically, these present to us like abscesses, necrotic debris, fibrinous debris, and we have to work with what we're given. Some of my thunder's already been stolen by Dr. Bartlett's, but back in 1998, there was a seminal study out of Italy that looked at the effect of debridement. These people, we would probably call this a pretty bold study today, but they randomized patients to either excisional debridement or non-operative debridement, conservative measures. So what did they find? They found that patients receiving excisional debridement healed at 95.5% and at a mean of 46 days, versus only 79% healed at a mean of 128.9 days. Huge difference between excisional debridement and conservative management. Well, as we already talked about, James Wilcox, he looked at the time to heal. This is the other cool figure from the paper. They found, as you can see here, that with less than 1 week frequency between debridements, the vast majority of these patients healed, and this was in about 4 weeks. Really what was interesting is that in this paper, the majority of patients actually healed within 2 weeks. Now, if we look at what's probably more common in our clinical practice is debridements 2 to 3 weeks apart, you really don't see a huge difference in the rate of healing or even much increase in their success. So why is debridement useful to us? What does it do for us? Well, it removes biofilm. It reduces the bioburden, both of the native tissues and the bacteria within the wound, and it removes the factors leading to chronic inflammation within the wound. All of this leads to help make this wound from a chronic wound to an acute wound, which ultimately leads to promoting healing. Now, ideally, we would do all of our debridements in the operating room. We control the patient's positioning, we control their lighting, we have an anesthetist there to manage analgesia for us, we have all of the latest hemostatic agents available, and we have unlimited assistance, essentially, and all of the equipment that we could imagine. However, in the operating room, it's expensive. Every patient has to pay their costs. We have to pay our anesthesia costs. It's an expensive place to be. Anesthesia has its risks. Our patients are at increased morbidity. These are not healthy patients generally, and we're putting them at a higher level of stress. It takes time. It takes time to get the patient into the operating room. It takes time to get them out of the operating room. They need recovery time. And then repeating that process is daunting. And finally, it takes us a lot of time just to get the patients in and out ourselves. And scheduling the operating room is never very convenient. Now in the clinic, we can control the time that the patient comes, the time that the patient stays, how often the patient comes. We can control where they go in our clinic. We can control how frequently they come back to the clinic. And it generally costs far less. There's far less resources. However, it generally looks something like this. We can't control the patient's positioning. We can't control the lighting. We can't control hemostasis generally. We have minimal tools at our resources. And patients complain of pain, and we don't have narcotics and anesthetic agents in the clinic to help these patients. So at Georgetown, we wanted to look at clinic-based debridement and see how effective it really is. We started with an approach looking at bacteria and seeing if we could significantly reduce the amount of bacteria within a wound just by clinic debridement. Well, what do we find? I don't want you to get hung up on this p-value. It does look like significant, but look at the means of our quantitative cultures. There's no log reduction. And it's well established that the standard for an effective intervention is a full log reduction. And here we have essentially the exact same counts. So we looked at this again, this time from the operating room. And we took patients to the operating room, we cultured them before debridement, we cultured them after debridement. And then we looked to see what those cultures showed. So we found that, again, we didn't attain a full log reduction, but overall we did obtain a 77% reduction, which a full log reduction correlates to roughly about a 90% reduction in bacterial counts. Now, there are some adjuncts that may be useful to us. A lot of this is still new technology and is unproven. In the same study, we looked at bacterial autofluorescence. Now, bacterial autofluorescence uses fluorescent light that is reflected by certain proteins in the bacteria at a particular spectrum of light. And when we shine this light on it, we can see where there's heavy bacteria versus where there's not heavy bacteria. And what we found was that in this study, that autofluorescence did correlate with our swab growth. Now, John Lancis's group has also looked at incisional vax, or not incisional vax, but negative pressure wound therapy with instillation. In this case, they instilled with 0.25% Dakins, which, as we just heard about, Dakins is very effective in managing bacteria. With this, they were able to show a full log reduction in bacteria and increased rate of healing. Before we go on, I just want to point out there's a new sponge. We call this the waffle vac at our institution. It's basically just large pore vac. There are studies coming out. Nothing's been published yet, but the studies are showing that it may be beneficial in augmenting our debridement, especially of those difficult to manage wounds with high fibrinous debris. So what does all this mean? So operative debridement does facilitate a more thorough, more complete, more comfortable procedure for the patient, but it does increase the risk to the patient. However, clinic-based debridement we can do more frequently and we can do with less resources. So overall, we need to do a combination of the two. Manage the patient operatively to overcome the majority of bioburden, and then we can do these frequent debridements in the clinic. And then adjuncts may, but still need to be proven, but they may improve our overall effectiveness. Thank you.
Next we'll have Dr. Jeff Manway up. He comes from Pittsburgh. He's involved with the residency program there. I'll get his thing up and loaded here. Thank you, Dr. Manway.
All right, so I want to thank everybody for having me here. Some of the things I'm going to talk about, I think Dr. Bartlett touched on a good bit. I think that stuff is paramount to what we're doing. Those things are truly the basics of wound care. If you're not adhering to that standard, people need to be getting on board. But one of the things that he did touch on was when somebody calls and says, there's pus coming out of my foot, or the nurse says there's pus coming out of my foot, or it's red, or it smells bad. On the telephone, I can tell you that about 95% of the phone calls that I field saying, oh, there's pus coming out of my foot, if I urgently give them an office visit, say, come in an hour, I'll check on you, I happen to be in the office today, I look and I go, what the heck is this person thinking about? This is somebody's pus. I'd hate to see what bad really looks like. And so differentiating what's infection and what's not infection is very problematic, particularly in these hosts. So I don't have any disclosures other than that I'm not punctual and I'm generally not brief, but I'll try and keep this to the allotted time. What does infection look like? And I think, the two on the left, most people would agree that this looks like infection. And the one on the right, maybe not. Who knows? You know, these ones, which of these are infected? You know, I think some people might say the one on the left is infected. Some people might say the one in the center. You know, maybe the one on the far right is osteomyelitis. So, you know, we have pictures, we have clinical exam, we have lab work. Does this person have an infection? You know, this foot looks, you know, moderately terrible, as we would say. But, you know, they have a white count that's normal, their temperature's normal, you know, their heart rate's 52. You know, they're surprisingly calm in this scenario. So how do we figure this out? So which of these people are infected? Well, you can see here, you know, some people may say some of it is obvious, but to a lot of the people that are your first responders or the first set of eyes that are seeing these patients, this is not so straightforward. So things really aren't always what they seem. You know, be careful. Be careful who you're relying on as your source of information, and how can we get better information that helps us make better decisions. You know, everyone is reliant on white blood cell count, and in the general population, probably for most people in this room, if you come to me and say my white blood cell count is 5, I'll say, all right, you probably don't have a raging infection somewhere in your body. Congratulations. But, you know, probably one of the first studies to really talk about this was Armstrong in 1996, where they looked at patients hospitalized not just with a DFI, but with osteomyelitis, and 54% of those patients had no leukocytosis. And so it's important to recognize that this is not adequate. So do we use just clinical exam? Do we use probe to bone like he was talking about? Are we talking about odor? I mean, I don't smell great. Most of my patients don't smell good at all. You know, Pittsburgh is where the large people who eat French fries on their sandwiches live. Odor is worthless to me, unless they're calling me saying, as the ER often does, there's somebody in base 7, we haven't taken off their shoe, it just smells too bad, we know that you are needed here. And in that case, I probably think odor has something to do with infection. But, you know, other markers, and I think an important note here is, he kind of touched on, you know, it's very easy to have someone call on the phone and say, I have a little bit of redness, I'm maybe feeling a little bit bad, I don't know, my sister was sick, she had a cold too, you know, what should I do? It's a very easy thing to just say, well, here's some Keflex, you know, and if you're not better in 3 or 4 days, then I guess I'll see you then. And this is a tremendously dangerous thing. I refuse to give any of my patients oral antibiotics over the phone unless they've had an evaluation by me or someone else that I can say someone has physically laid eyes on this person. It's a pain in the butt, and I've had people threaten me, I'm going to sue you, you didn't give me an oral antibiotic. Listen, if you're so bad that you were thinking you needed an oral antibiotic right away, then you needed to be in the hospital anyways. And if your infection is such a rager that you're losing your leg tomorrow because I didn't give you Keflex, then Keflex wasn't the right choice. So, you know, looking at clinical exam, obviously he touched on a lot of these things, and so, but it can be obscured. We have peripheral edema, we have peripheral arterial disease. These things cause redness, they cause cold, they cause warmth. You know, maybe you have antibiotic suppression because somebody called their family doctor, whomever, before they talked to you, and they've been on Keflex, and then they were on Cipro, and now they've been on Bactrim, and in the last 6 weeks they've had 4 courses of antibiotics. So how are we diagnosing these things? It's important, as Dr. Bartlett said, to get baselines for all of your patients. Probe to bone, this is a hairy thing. You know, it's been shown as a good positive predictive study if you're getting to bone, and I think probably the most important thing with probe to bone is that you're reproducible within yourself. You know what bone feels like to you, and you've felt about 1,000 people with osteomyelitis, and you get some good sense of what is going on. But it's got a poor positive predictive value, rather. It's good negative predictive value, but poor positive predictive value. And then advanced imaging, which we're going to talk about after this. Obviously, you want to have some sort of conjunction between what you're seeing clinically, radiographically, laboratory. So looking at X-ray is moderately sensitive, moderately specific. Bone scan is certainly more sensitive, but terribly specific. I can tell you in 6 years I've ordered 0 bone scans for any of my patients, and I'm proud of it. I think it's an absolutely worthless study, and if you truly feel that there's osteomyelitis there you don't know, then you take them to the operating room and you do whatever cultures or pathology. That said, there's no agreement amongst pathologists really on what chronic osteo looks like under a microscope either, so that gold standard is, I don't know, not so gold. MRI is probably the best, but it's an expensive study, obviously. It's not easy to get in the emergency department to say, hey, go to the ER, we'll get you a quick MRI. That happens never. So are there other things that we can do? You know, as I said, advanced imaging is very costly. It's not a great tool for triaging patients. It can't be done in a timely fashion, and sometimes it even overestimates disease. But labs are not just for inpatients. And I utilize this not only as a baseline for my patients, but if I see something in the office and I say, I'm not quite sure. It's been 4 weeks and you haven't really gotten your 50% reduction in surface area of your wound. It's time for us to get some new labs on you. Is there something low-grade brewing here? I get a SED rate, CRP, CBC, basic MET panel, and A1C. I get prealbumins on my patients and vitamin D. And then there are these other things that you can look at that are sort of questionable: procalcitonin, neutrophil, lymphocyte ratio. This is a patient that comes in and, their white count is 13.9. We look at, their CRP is 22, their SED rate 76. There's obviously something happening with this patient. And, it takes some commitment on your part, but if somebody comes in on a Friday and you say, listen, I honestly don't know, and you're feeling pretty good, I have a Quest downstairs in my office, and I say, go on down there. Quest has my phone number. If there's a critical value, they're going to call me about it. But you say, listen, if you haven't heard from my office in 24 hours, call me. But, these are important tools that you can use. And I think probably the best thing I can tell you is it's just not for inpatients. It doesn't take an emergency department to get you a SED rate or a CRP. But acute phase reactants, what I'm really here to talk about, it's kind of a misnomer. And we are measuring both chronic and acute. So CRP is more for acute inflammation, SED rate maybe more for chronic inflammation. But these are proteins that may increase by more than 25% in the setting of inflammation. It's important to note that there are positive APRs and negative APRs. Like Dr. Bartlett was saying, albumin is really more of a negative APR. Albumin is a terrible indicator of healing potential in the setting of infection. I've seen people's albumin recover handily just by controlling infection. They come in there 1.9 or 2.0, and in 2 weeks you've done maybe nothing to optimize their nutrition, although you should, but the infection is resolved, and then their albumin is magically 3.7 or 3.8. Prealbumin seems to be a little bit better, but it does take a little bit more time to get that value back. But we're talking about positive APRs mostly, looking at CRP, fibrinogen, alpha-1 antitrypsin, procalcitonin, questionably, depending on who you read. And CRP is the quickest to come back. This was the first acute phase reactant to sort of be discovered in the setting of pneumococcal pneumonia. We don't really know what normal is. I think most reference ranges are under 1 or 0.8, but it's different from male to female, and the reference values as reported, this is something you have to be very, very careful about, because it's reported as milligram per liter, milligram per deciliter, gram per liter, and you'll look and you'll say, man, this person has a CRP of 70. They must be like dead. I've never seen one so high. And and then you look at the reference range and you go, okay, so I'm used to seeing this in milligrams per deciliter, and Quest now has changed their policy, at least in Pittsburgh. They're doing sort of milligram per liter, and then I have to bust out my calculator so I can multiply by 10 or divide, whichever direction you want to go. And then there's this other thing of high sensitivity CRP, which our neighbors sort of downstairs and around the hall will see, and it'll say cardiac CRP a lot of times, and you'll say, well, I can't use that. I'm looking at their foot. I don't want to know anything about cardiac, nothing. This is, and you're calling the lab and screaming at them, you did the wrong study. I picked the other one. And in reality, it's the same study, just a different assay. The high sensitivity CRP is actually more sensitive for low values of inflammation. And so it may be a good thing for us differentiating, am I getting better as far as infection is concerned? This study will do a better job of saying 2.6 down to 2.0 is a clinically significant value, rather than, just getting our other basic CRP. So looking at the sensitivity of this, it's fairly sensitive for detecting infection between 88 and 94%, particularly values over 10 milligrams per deciliter. And then its partner ESR, which is a great study but can be a little bit unreliable if you're not paying attention to who your host is. Again, this is sort of different for everybody based on age, based on sex. It's an indirect measure of fibrinogen, so I think that's something to understand. It is an indirect test for inflammation. In many studies, it seems to be the higher the ESR, the more specific that is, the more sensitive that is for infection. We don't have one great value that says this is definitely infection, this is definitely osteo. But for example, things that may influence ESR, age. So somebody at 55, their ESR may be more like 35 or 45, which you may interpret as moderate inflammation, but that just may be normal for them. The big one is renal disease for us. I can't tell you, I'm sure all of you know how many patients we see with chronic foot wounds and are stage 3 or stage 4 kidney disease or are on dialysis. And when you look at the numbers for this, it's pretty impressive. 100% of patients with stage 2 kidney disease will have an elevated ESR. About 20%, particularly ones who are on dialysis, will have a chronically elevated number greater than 100. So when you're looking at something, you say, man, their ESR is 125. This didn't really look that bad to me. Then you have an artificially elevated ESR from their kidney disease. So rate of change, I think, is important to note. Your CRP is going to drop first. That's probably going to normalize within 2 weeks, whereas ESR may take 4 to 6 weeks to normalize. But it's important to check these things weekly or at least every 2 weeks to make sure that you're making some headway with treatment of your infections. And then some of their partners, which things are being sort of studied. Procalcitonin, this is the, I think, big en vogue one over the last couple of years. And it's certainly been shown to be specific for diagnosis of sepsis in an ICU setting from a bacterial source, but we haven't done a great job of correlating it with diabetic foot infection. In our own institution, we've sort of followed this over the last 3 to 4 years and have really found no significant difference for osteomyelitis with procalcitonin versus diabetic foot infection versus sepsis. We can't seem to find any sort of value that says, this is clinically significant for determining whether there's something that's osteo. And the literature kind of reflects that as well. There are a few studies that say, yes, this is definitely a good way to determine this, and that the higher the procalcitonin goes, the more likely this is to be osteomyelitis. And others, it shows that it's not really advantageous. So probably the most recent large study came from Zagonis down there at UT San Antonio, looking at these values. And what they found is using them together, they're very sensitive for determining whether somebody has an infection. So, ESR, almost 100% sensitive in their population, with values over 83 for having a moderate or severe diabetic foot infection, and CRP as well. Whereas, correlating this with imaging and pathology particularly did not do a great job at 77%. You'd think, boy, directly doing something, looking at something would be great. But it doesn't seem to be the gold standard that we've thought that it is. Then MRI actually performed very well, which I think we're going to talk about coming up here. So sort of what are my thresholds? I use this number from Coletta in 2001, the 70 millimeters as an index of suspicion for osteomyelitis. This is sort of my trigger in the right clinical setting for ordering advanced imaging studies. So I use these as sort of my opt-in. If I have people with these elevated inflammatory markers, I say, well, I'm not going to stamp this with osteomyelitis unless I say there's obvious erosive change here on x-ray. What I will do is get an MRI of that person and use it as sort of my own personal triage of how I'm taking care of my patients. Or if it's 50, then I say, well, maybe we monitor this for a little bit. This is probably not osteo. 67 from McHale in 2013, so relatively consistent with this. And then other studies have shown basically the higher the number goes, the more likely it is that it's osteomyelitis. And then CRP, again, we have to watch sort of the numbers here. So, McHale in their study, 14 milligrams per deciliter. Fleischer in 2009, only 3.2 milligrams per deciliter. But in theirs, in conjunction with a CRP greater than 60 and a wound depth greater than 3 millimeters. So, again, sort of this is just from Zagonis's study. These sort of numbers all remain sort of consistent. ESR greater than 70 seems to be fairly specific for osteomyelitis. And then SIRS, as Dr. Bartlett touched on, and so this is not necessarily an inflammatory value or marker, but it is a marker of systemic inflammation. And this is a very simple thing. I can tell you most people meet this criteria if they're showing up at the hospital. Yeah, as he said, heart rate greater than 90, elevated white blood cell count, elevated temperature or respirations, or metabolic disturbance as well. If they're having acute renal insufficiency, that's also part of SIRS criteria. And then this was validated by Dr. Wukic in 2013, looking at being able to differentiate between moderate and severe diabetic foot infections and their risk for amputation. And so SIRS is definitely a good criteria for using to try and differentiate the severity of infection. So sort of my final thoughts. These are not just for the hospital, as I said over and over again. I get these labs on people all the time. If I get an elevated study, I say, listen, go to the hospital. I don't know what to tell you. You're feeling fine. Your labs say otherwise. I think erring on that side of caution, and then at least people feel like you're doing something for them, rather than just calling on the phone and saying, man, he said to go to the hospital. I don't really feel that bad. These labs are ubiquitous now. It is not hard to get people over to a lab, or even your hospital's outpatient lab, in which case the hospital sees a critical value. They're going to tell the patient to stay, but it doesn't need to be a $100 ER copay for that patient. And it gets you a lot of information, quite honestly, more so than a lot of even the frontline staff at the hospital will give you. So, thank you.
Next, we'll have Dr. Walters back up for osteomyelitis in the first MPJ.
So before I get started, I've kind of been listening to some of the chatter in the room. Can I just get a quick show of hands? How many people here are actually podiatrists? Okay. I don't really know that I need to say more than my title slide. You all know the importance of the first metatarsal phalangeal joint. We look at the size of it. It's clearly the biggest and therefore the best metatarsal in the foot. But I always like to take things back to evolution. Why did evolution make us with such a big first metatarsal? It's because it's so important to our function. If we look at the foot, we have three main points. We have three main arches: our medial, lateral columns, and our transverse arch. And this all reminds me of a Roman arch. Everything is directed towards the center, and then that weight is distributed out towards the points. The first toe, I believe, is like the flying buttress of our Roman arch. It does not supply the primary weight-bearing source, but it is an adjunct to it and helps to improve its weight-bearing and its use. We like to think of this as a happy tripod, but unfortunately it ends up being more like this, especially in our patient population. Several abnormalities that we see leading to this are hammer toes, claw toes, mallets. They present with the circular pattern of pressure ulcer, usually found on the plantar to the first MTPJ. We also get distal tip toe ulcers that can lead to osteo, and dorsal PIPJ ulcers, which can lead to osteo. Hallux rigidus will lead to the same pattern of circular ulcers on the plantar surface or the distal tip. And our hallux valgus ulcers will lead to more of a lateral metatarsophalangeal joint ulcer. This tends to be more oval-shaped, relating back to its source as a function of shear rather than pressure. Now, when we think about osteomyelitis at the first metatarsophalangeal joint, because of the importance of it in our arch, when things go wrong, when we develop bad osteo and we have to resect, then everything just collapses. This arch fails, our patients fail, they fail to ambulate, their comorbidities worsen, and that ultimately leads to their inevitable demise. So what do we do? Do we cut this out? Do we not cut it out? What can we do to treat that? So at Georgetown, I should also mention that Tom Rukas did a pretty seminal study on this, showing that patients receiving first-ray metatarsal amputations have an exceedingly high rate of additional higher-level amputations. This is everything from TMAs to below-knee amputations, above-knee amputations. When we take the first ray, it just starts the train rolling, and then we keep cutting. So a few years ago, my predecessor, Tamer El-Marsafi, he looked at placing permanent spacers in these wound locations. When we take out the first metatarsal bone and we put in an antibiotic spacer that's antibiotic eluting, what happens to these patients? So ultimately what we found was that these patients, some did fail, but they failed at a mean of 20.9 months. So think about that. You have almost 2 additional years on this patient with a closed, healed ulcer. Now, obviously we don't want to set up our patients for future amputations, but overall, we found that 66% did not fail, and this is the most important thing, all of those that received the spacers, including those that had to be removed, remained ambulatory. So of those that didn't fail, that 66%, they continued to ambulate. And those that did fail, for those 20.9 months, also continued to ambulate. Okay, so what if we don't have to cut out the bone? What if we can catch these patients early before there's complete destruction of the joint? So a group out of, this was Italy, this was Spain. They looked at a 12-week regimen versus surgical resection. These patients were prospectively randomized to receive either resection or antibiotics, and then they were followed for about a year. And what did they find? They found that 75% healed with antibiotics alone, which was not statistically significant to surgery. So they were able to save these patients' first metatarsal joints, reduce their risk of future amputations, and keep them ambulating with a 12-week course of antibiotics. Furthermore, a subsequent study, this one came from France, they looked at this 12-week regimen and said, well, what if we can cut it down? Maybe we can get these patients through with only 6 weeks of antibiotics. So what do they find? Same thing. 90% healed with 6 weeks of antibiotics, and they went on to walk again. So what does this mean? First metatarsal joint, as we all know, is exceptionally important to managing these patients and keeping them healthy, not just their feet, but also their whole body. Saving this joint, if we can, is ideal, and we can do it with ultimately or potentially a short course of IV antibiotics. However, if we do have to operate, antibiotic spacers can reduce the recurrence and keep the patients ambulating. So thank you.
Next, we're going to have Dr. Osher come up and talk about radiographic imaging for infection. I think he's on his way. Get his lecture started here. All right, he's on his way. Just real quickly, we're going to, the morning, we'll get back to 11:35 with Dr. Carmen, and we'll get to our regular lunch break that we're supposed to have. The food will be out here before our lunch break. Osher and I will be speaking at the end here. Towards the end, if you want to kind of go back and forth to get food and come back in, it's not a problem. That way we can kind of get settled for competition. So we'll kind of get back on the schedule which you have in front of you at 11:35 with Dr. Carmen. That'll take us to the lunch break, which will be on time, and we can get the food and get to interview the residency competition. And I'll pull all the residents before the competition and put them in order, okay? All right, I'm going to start with this, and then we can have Dr. Osher come in. I don't have anything to disclose. I want to talk about MRI and clinical correlation. I'm an MRI person for a couple of reasons. It's a modality that I can look at and that I can learn, and that I can get frequently. And I've practiced in rural West Virginia my entire career. I've not come to a facility where I cannot obtain an MRI. Some of the more advanced imaging techniques that you see discussed are not offered at every hospital. As an example, you can get the advanced imaging techniques at WVU in Morgantown, CAMC in Charleston, and that's it in the state of West Virginia. Whereas I can get an MRI almost at any hospital. So I think it's important that we have some basic understanding of MRI when it comes to looking at infection. Let's get through that. Kind of done that already. So here's what you want to avoid. I'm going to kind of show you the good, the bad with both sides of the coin with respect to the radiologist standpoint, the clinician standpoint, and what we have to kind of move away from. So this is what we give the radiologists. We say that there's a 51-year-old diabetic with a left foot problem. I mean, that's what they get. They don't usually get a history and physical. Most of the time we don't call them. And so they're really put at a deficit. They don't have any information a lot of times as to what they're actually looking at, the clinical course. We need to move away from that as practitioners. We need to, and I try to communicate with the radiologist, hey, I just did an MRI, you're going to read it tomorrow or this afternoon. Here's what's going on with the patient. Send them an email, send them something, because that's going to help them with that initial read. You have to make sure that you do that. Now here's the problem on our end. The radiologists aren't good with communicating with us either. This is what you typically get, right? No definitive evidence of osteomyelitis. We need to clinically correlate it. And of course, they're going to recommend you to get another test in 7 to 10 days. We don't get really good information a lot of times from our radiologists when we look at the impression. But here's kind of the bottom line, and this is a great quote, and this is out of an orthopedic journal, and I think it's true. Other than looking at straight anatomy, you're looking at CTs or MRIs, you can say orthopedists and podiatrists are not good at utilizing these tools and maximizing their utility. We're not good at looking at different pulse sequences, know what that means, and how that applies to a specific patient. And so I'm going to start off with the knee thing, and I don't take care of knees, so I started working with MRI with a radiologist by the name of Frank Seidelman. And at the end of my residency, he and I got together and we looked at all of his foot and ankle MRIs. It was about 1,600. And we looked at specific things. We wanted to look at the peroneus quartus tendon. We wanted to look at specific anatomic structures. My first day, I'll never forget this, he showed a sagittal cut of a knee, a water-weighted image, a stir, and he looked at it and said, that patient has an ACL tear. And I said, how can you know that? He said, well, there's secondary signs for ACL damage. Contusion of the lateral part of the knee, both the femoral condyle and the tibial plateau. There's different angles between the ACL and the PCL. There's all kinds of things that we look at as secondary signs that are very accurate and portend towards an ACL damage. So this is just a paper that was done, I think last year, 2017, and they looked at the peripatellar fat, and it's very sensitive as a secondary sign for an ACL tear. So why am I telling you that? Because the same thing holds true in the foot. Okay, TP tendon. How many times do you see inflammation in the subtalar joint? You see some damage to the distal medial malleolus where the TP tendon courses around. You see signs of pronation on MRI with respect to your water-weighted images and inflammation. These are all secondary signs of pronation that point towards a possible TP tendon rupture. So we take that and we just apply it to the infectious process. So here are some primary and secondary MRI findings with respect to osteomyelitis in the foot. And it's really kind of interesting. Most of these papers were published by a guy named Mark Schweitzer. And they were published mid-90s to 2005. So this is old information that we really haven't utilized as much as we possibly can. So if you look at this, the most important things are, is there a sinus clinically? Is there cortical interruption on your plain film, or clinically can you appreciate that when you examine the patient or when you operate? And is there an ulcer? Those are the most important things with respect to these primary and secondary findings and looking at an MRI and calling it osteomyelitis. So here's a great example. This guy came in to the office, had a red hot swollen IPJ. He had a septic arthritis. He came in August of 2016. I admitted him to the hospital on a Friday. I opened him up that afternoon, cleaned out his joint, cultured it, left it open for about 3 or 4 days, and then a delayed primary closure. He was maintained on culture-directed antibiotics for about 6 to 8 weeks. His wound healed up. He did fine. Here is his clinical picture 2 months after his antibiotic course was completed. There's his radiograph that corresponds to that clinical picture. So we have a sinus with drainage at a previous area of septic arthritis. We have radiographic changes on plain film. And then here's our MRI sequencing. And we'll get into some of the T1 and T2 stuff a little bit later. But basically, you cannot visualize clearly the cortex. And Dr. Osher is cringing back there that I say this. But I can't visualize the cortex with respect to the distal phalanx. The distal phalanx has lit up. These are all water-weighted images. And so this is what we had clinically. I amputated his toe, and that's his distal phalanx cut sagittally in half. So that lytic area that you saw on plain film corresponds to this pus in the middle of his distal phalanx. So I think it's really important that we try to put all this stuff together. And it's not just important for the patient you're treating, it's important for the next 2, 3, 4, because each step along the way, you learn a little something different. And you're able to utilize these tests a little bit better and get more information so you can treat patients better. This is a better one. So if you look at the left-hand images, clearly with respect to the fifth metatarsal head area, there's a soft tissue deficit on all 3. We can't visualize the fifth metatarsal head on all 3. And then on the sagittal cuts, the fifth metatarsal, these are water-weighted images, so high signal intensity is suggestive of inflammation. And this is the best part. This guy is in his mid-60s, had a crush injury when he was in his 30s, open fracture, lost his second, third, and fourth metatarsal heads, so he's walking on his fifth met head, and his general surgeon was taking care of him, and he walked into the office like that. So that MRI corresponds to that clinical picture. So I think it's really important that you try to put this stuff together every time you see these patients. You learn a lot. And so obviously when I saw that, I know that the fifth metatarsal infected, and I just lucked out because the protocol for my patients at this hospital is they get an MRI on almost all my patients, and they got it for me. They said, "Aren't you happy we have it?" Before you saw the patient. I said, "Yeah, I am, but we probably didn't need it for this patient." It was a good test to get, but you know, that was probably not something you needed on. So let's look at some T1 weighted MRI characteristics for, and this is probably the most important thing. This is where you can look at an MRI and really start to learn about clinical presentation, what you see clinically, radiographically, and then look at the MRI and put it together. So there's some primary MRI findings. So we usually get a decreased T1 signal on MRI with osteomyelitis. We get an increased T2 signal. And there's post-gadolinium enhancement. I'll let Osher take care of the gadolinium stuff. But just as a general rule, T1 weighted images are anatomy images. Okay, and when we get T1 weighted images, the bone should be white. Okay, and those are our anatomic images. That's the best study for anatomy. Our water weighted images, T2 weighted images, or STIRs in general, look for inflammation. So with any musculoskeletal process, whether it's infection, whether it's a stress fracture, whether it's an osteochondral injury, whether it's a TP tendon rupture, I want T1 weighted images and T2 weighted images, or STIRs, I prefer STIRs, in all 3 body planes. And if I can get that on every patient, I'm happy. Because the T2 weighted or STIR sequence gives me inflammation. I pair that up with the anatomic T1 weighted image, and that helps me put the picture together with my clinical exam and history. Now, one of the things that you have to be careful of is looking at fat-suppressed T2 weighted images. They tend to overestimate findings for osteomyelitis. So we're going to go through a couple cases here, and we'll talk about some of the distribution and patterns with respect to T1 weighted osteomyelitis findings. Distribution, it can be either geographic medullary versus subcortical, and I'm going to show you some examples of this. And then the pattern can be either confluent, reticulated, heterogeneous. And so let's go. And so on the top image, that's your water-weighted image. Oh, do we have a pointer to it all? Is there a pointer anywhere?
Should be on the podium.
So you look at this. This is my water-weighted image, and this is a fast spin echo T2 because I have pretty good anatomy, but I've got inflammation. The bone should be black, but look at this. There's inflammation there. And then I go to my T1 weighted image where the bone's white, and the entire bone is washed out. They call this kind of a ghosting of the bone. So when I go to my T1 weighted image and I have this gray, okay, I'll have hypointensity or a low signal, that confirms to me that this just isn't inflammation, but it's probably osteomyelitis. This is a BKA water weighted image. The entire bone lights up. T1 weighted image, the entire bone has this kind of gray hypointensity. This will be a kind of a medullary appearance, and that is consistent with osteomyelitis. So now let's look at this. This is an ulcer sub 1. We do have some bone inflammation here. This is a water weighted image. But now when we look at the T1 weighted image, and this is the take home message of the whole lecture, we get this reticulated, heterogeneous appearance of hypointensity in the first metatarsal head. This was culture negative. This was not osteomyelitis. So look at the difference. We have some bone inflammation on T1, on T2. We really don't see the same kind of appearance on T1 with respect to this as we did here or here. And that's the take home. That's the big difference. And you really can gain a lot of information. So let's look at this. We have a little bit of bone inflammation. We have a superficial kind of ulcer with some inflammation. T1 weighted. But this really is kind of a subcortical reticular pattern. This is not consistent with osteomyelitis. And I'll show you a great clinical picture of that in a case of that in a minute. This, on the other hand, we have inflammation. We've lost the cortical definition on both the water-weighted and the anatomic image. There's an ulcer. This was consistent with osteomyelitis on biopsy. So here's a great example. This is a water-weighted image. This is a fast spin echo T2. We have pretty good anatomic detail with significant inflammation in the calcaneus. Here's the T1 weighted image. I think you can 99% of the time say that this is osteomyelitis. This is a significant medullary hypointensity that corresponds with the hyperintensity on the water-weighted image. So let's get to the clinical case. This is a great case. This guy is 6'7", 350, okay? He has this ulcer, and he's had this for 22 months. He's had over $100,000 of wound care products put in this hole in the bottom of his heel. He's been seen every week to 10 days for 22 months. Is it surprising to anyone that this isn't healing? He's walking on it, he weighs 350. I mean, it's never gonna heal. And that's one of the things we talk about, modifiable risk factors. This guy is gonna be hard to treat. And when I saw him the first time, I actually saw him before this picture, I said, if you don't stay off of this, this is just not gonna heal and you're gonna have a problem. He had just had a debridement. He had some stuff pushed up into this wound, and about a week later he came to the ER. His white count was 20,000, his CRP was elevated, his SED rate was elevated. He was sick. SIRS were all up. He was a sick guy. So we debrided him. There's his plain films. You can see the subcutaneous emphysema. And we got an MRI. I got the MRI before the debridement. He did have a retained foreign body, a small piece of metal that happened years ago. That's the artifact that you see. So now let's look at the T1 weighted image and the water weighted image next to it. Can you guys see the pointer? Not really? Yeah. So if you follow, just look at the water weighted image of the T2 all the way across. And anytime you see anything that looks questionable, like right here for instance, go to the T1. The T1 has no medullary hypointensity. So in this whole way across, he's got inflammation outside the bone and maybe a little bit within here, but nothing that corresponds on a T1 weighted image. And why is this important? Because I've debrided this, I've done a full thickness removal of all this lateral soft tissue. The question is the bone infected? and people are asking me to get a bone culture. Based on this MRI, the cortex hasn't been violated on any of these T1 weighted images. Do I see anything that's significant for osteomyelitis? So I'm not about to go through the cortex and expose the entire calcaneus to this infectious process. So I did not biopsy this guy. He went back for another operative debridement, and here's just the sagittal cuts where you can kind of see the same thing. The T1 weighted image never demonstrates anything consistent with osteomyelitis, even though there's significant inflammation from the skin to the bone, and maybe a little bit here, subcortical, but it's not that impressive. So this guy was managed on antibiotics, and I actually got lucky. This guy was sick. Post-op, the second surgery, he ended up crashing. He had a significant pulmonary problem, got intubated. He was in the unit for about 10 days. Well, that was great for me because he's not walking on his foot anymore. And to be quite honest with you, it helped. And so clinically, there's what we have. And this is about 6 weeks after he went into the hospital. There's his lateral wound. I did not put anything on it, and I'll tell you what I used to treat it. Betadine ointment and sugar, 30 grams of betadine ointment, 2 tablespoons of sugar. Cost $6. That's what I treat all these people with. There are his films. We kind of follow them sequentially. Now, I got a call from the nurse. He's home now, and said, Mr. So-and-so fell in the yard. I'm like, well, what's he doing in the yard? Well, he went outside to pick up all the sticks in the yard. And I said, well, you know, we're done now, because he's now walking on his heel again. So he's walking on his heel, but he believes in this betadine and sugar thing, so he's getting some honey products sent to him from somewhere outside the country, and he's mixing it with his own sugar, but he's doing it on his lateral side. The inferior ulcer's getting bigger. Here are his x-rays. And now that looks like it did to start off with, right? The inferior heel wound. But the lateral wound's kind of healing up and doing well. He went through his 6 to 8 weeks of oral antibiotics. We did step-down oral antibiotics, which are culture-directed. He grew out methicillin-sensitive staph. I'm going to let Osher take care of this, but we're going to go to his next x-ray. So I got called from the ER, and you notice this is almost a year to the day when I first started treating him operatively. The ER doc called me and said, hey, your guy so-and-so came into the ER. He's in a lot of pain. And I will tell you, almost any diabetic patient that you see with a bad infection, even if they have neuropathy, if you get a phone call and they tell you that they have pain and you know they have neuropathy, that's someone that you need to look into. Because when they have pain and they have a history of diabetes, typically that's for a reason. And so this guy this was truly a pathologic fracture. From Osteo, I believe. And do these images look that way? Why do these look this way?
It's a bad connection with the cable. But it won't be presented like that.
So on these images, what we're seeing now, there's definitely inflammation within the bone, okay? There's a sinus, there's necrotic tissue, there's enhancement on these lesions, and Dr. Osher can take care of this part for me. But basically what we see is there's a much different appearance in the calcaneus now. So this guy got debrided a couple of times, and we'll go past this. There's his ulcer. I cut the entire thing out, debrided him, and essentially the ulcer tract went up into the subtalar joint through the fracture line. We cultured that, and we percutaneously fixed his calcaneus and put a very small X-fix on. End of the day, the X-fix was taken off. The fracture didn't heal. We left it on for about 3 months, but he ended up with a VKA. So not a good result, but an excellent learning case with respect to looking at MRIs and trying to correlate it with your clinical presentation. So now I'm going to let Dr. Osher come up and speak about evaluating infection radiographically. Dr. Osher?
Well, thank you. Thank you for inviting me. Pleasure being here. Nice seeing you again. Not sure why you had all that pixel dust. I don't know if that's the projector or not, but we good? Yeah, you have a lot of pixel dust here. So, is that your projector going or what?
You just put your truck right there.
Yeah. Oh, heck. Sorry.
Why does it?
It's pixel dust. Yeah. Is that the projector? Or...
Here, that's you right there.
It's me.
Yeah,
Right.
good stuff. Yeah.
Okay, I'll try it again. Okay, well, it's a tough act to follow, Dr. Shook. We're going to try to focus on MRI scan and hopefully not have too much redundancy in MRI findings of infected foot. I'm going to focus really on, as Dr. Shook said, going to kind of move over towards the use of contrast-enhanced images. Now that I'm down to 20 minutes or so, I really need to cut back on the crap. I love this little thing that I got. Anyway, so I think we all know that some of the statistics behind it. The only thing I want to emphasize here is bullet point number 2, that when you have clinically uninfected ulcers, there have been a number of studies that have demonstrated, Dr. Lipsky in England and whatnot, have shown that up to 15% of these ulcers will clinically have osteomyelitis. So even though it clinically looks indolent, you may still be looking at this. We saw earlier that we looked at some of the expert opinions through the IDSA guidelines, and so MRI is a established way to go from plain film radiographic imaging. The value, as you've already heard, of bone biopsy, and especially in terms of histopathology, has been questioned a bit. The Andrew Meyer article on JFAS in 2011 pointed that out, but I think that maybe that's overplayed. There were some problems with that study, but certainly bone biopsy is considered the reference or gold standard. So I'm going to kind of skip through this stuff because we've kind of pressed for time here a little bit. Let me just talk about MR imaging of osteomyelitis to start. What we're looking for is a replacement of the marrow signals on both T1 and T2 weighted images. So, T1 weighted images, you're looking at the replacement of marrow fat and with a water, basically. And water lowers that signal intensity as you lengthen the TR and TE relaxation times of the tissue. And also brightens it on the T2 weighted images or heavily water weighted images. So it's kind of a straightforward thing. And the standard is, once again, marrow edema. Now, what Dr. Shook was talking about, based upon the work of Collins, is to move from the just basic mindless saying that we've got some marrow edema, to point out that the location, basically, of involvement and the pattern of involvement is very important. The key word is geographic that I would point out besides reticulated. If it's subcortical and it's a subcortical location and you look at T1 weighted images, it's probably not going to be osteomyelitis. If it's geographic, which means large area, and it's medullary, simply put, it's probably osteomyelitis if you're looking at T1 weighted images. But we're going to go through this in a little bit greater detail here, I think. Okay, so let's look at some images. This is typical water-weighted image, fat-suppressed water-weighted image, and you see significant marrow edema in the proximal phalanx and distal phalanx on the sagittal image. And there's an ulcer tract, which is where our little arrow is coming in here. And so we have secondary signs. We don't have a lot of cellulitis here, but we have massive geographic inflammatory changes of the marrow. And I would still tell you at this point in time, as Dr. Shook has emphasized, make sure you look at the T1 weighted images. Although this massive amount of marrow edema is most likely going to be osteomyelitis. It's the T1 weighted images that really tell us it's a litmus test as far as I'm concerned. For starters, you already heard that you can overestimate the extent of marrow involvement with the water-weighted images. And one of the things that I should take a step back with the expert opinions in IDSA is that we're so used to making a diagnosis here of osteomyelitis, but those expert opinions we're talking about, not so much making the diagnosis of osteomyelitis, but determining the extent of involvement. It was debatable as to whether it should be used to make the diagnosis of osteomyelitis, because once again, they were talking about using bone biopsies as the standard or gold standard. So once again, most sensitive water-weighted images, most specific T1 weighted images for osteomyelitis. And you would not want to use, once again, you do not want to use any kind of water weighted image to determine the extent. Many times the extent is different on the T1 weighted images. That's proven to be reliable. Let me talk about contrast enhanced images in a second, and the extent also, because I don't know if I'll get to my later slides, but here's a T1 weighted image, and what we see here is cellulitis. So cellulitis is replacement of the subcutaneous adipose tissue with gray. It's water. You're just spilling water into high signal fat. You're graying it. It's also thickening, and it also has wide zones of transition. So here you see cellulitis over the lateral aspect of the foot, the calcaneus, and then you see what looks like on this first image, probably not, even though it looks subcortical, it's probably more geographic, larger area. And here it is considerably geographic, so this most likely meets the standard for osteomyelitis. And this is now, once again, Dr. Shook has talked about ghosting. When you have loss of the cortex or cortical edema, same difference, where the cortex, which is normally low signal, turns gray, you're not going to see it on the T1 weighted image. Usually fat is one of the universal substances to contrast water against, and now fat is going gray, water, the cortex, which is jet black, is going gray, and the marrow cavity is going gray. So all this grayness means the bone is just turning invisible, so-called T1 weighted ghosting, which is one of the things that we see. But really, you could sit there and say it's just geographic involvement of the marrow. This is a contrast enhanced imaging, which we're going to talk about in a bit, and we don't see any enhancement of the bone. When you add gadolinium to the T1 weighted images with fat suppression, where the GAD goes, basically many times reduplicates what we see on the water weighted image. And so for the diagnosis of osteomyelitis, I don't know that it's really necessary. In this particular case, what we have is enhancement where the arrows are of the soft tissues, but we don't see any significant enhancement of the bone. And so one would suggest this is cellulitis without osteomyelitis. If you think that in this cross-sectional image we're losing the ability to see the first ray on a T1 weighted image, you're right. This is what we call ghosting. And so this is geographic loss of marrow signal along with cortical edema and possibly erosive change. It'd be hard to tell the difference. And soft tissue, all that gray makes it an easy diagnosis. So with cellulitis plus osteomyelitis, in the upper area here you can see an ulcer, and below that you see a low signal area that's soft tissue gas or emphysema, which is non-enhancing. When we look at our water weighted images, once again, high signal marrow edema is less specific, more sensitive, but we always have to temper that with a T1 weighted images. So let me quickly get to a quick case review. And we're going to start, well, you know something? Let me kick over here. I'm going to skip to, let's look at gadolinium here for a second and talk about the diagnosis of the abscess. So the great value, I think, of MRI scanning in the infected foot, if it's controversial as to whether or not to make the diagnosis of osteomyelitis, but to establish the extent is fine, I think the great value of MRI is to look at what happens in the soft tissues, things that we cannot necessarily perceive otherwise. And so soft tissue issues such as abscess, cellulitis, which we've also seen, and we're going to get to necrotic tissue, are the strong suits of MRI and the diabetic foot are in the scenario of infection. Now, abscess is the same thing as cellulitis in terms of signals, but now we have sharply defined boundaries, all right, and the zone of transition is sharply defined. So when we add contrast to this, we get something called rim enhancement. So here's an example of a lesion in the tarsal tunnel. You have a T1 weighted image that's intermediate to low signal. It's sharply defined. And you see the flexor retinaculum out there. I don't know if we have a pointer, so I'm just going to kind of talk about this. Sorry. And then what you see on your T2 weighted image, the signal is homogeneously high signal and sharply defined. And the question is, at this point in time, if this was a scenario of infection, all right, you might suspect that this is an abscess. Now, I wouldn't suspect infection because after Dr. Shook's clinical presentations, there are absolutely zero secondary signs. How is it possible for you to have an abscess in the absence of any inflammatory signs, for example, at least of the soft tissue? But let's just say the abscess is a consideration. The other thing we don't know is that the MRI looks at the total amount of cellular water on the water weighted images, all right? That doesn't mean it's fluid-filled, because you could have rapidly dividing cells without a cellular water, and this could be a solid mass. We don't know right now. One of the great uses of gadolinium is a T1 contrast agent, and it's bright on bright, so we always add fat suppression to T1 weighted images. When you add gadolinium to this scenario, the patient's injected IV with it, this is the T1 weighted image with fat saturation. And what we see is the gadolinium is accreting or gathering around the lesion, but is not taken up centrally by the stroma of the lesion. This tells us that this is fluid-filled, and so we now know that this is not a neurolema or a schwannoma or anything like that in the tarsal tunnel, and it turns out to be a simple ganglionic cyst. And certainly this is exactly what abscesses do in the scenario of infection. We see they're rim-enhancing discrete lesions. So here's a T1 weighted image that we saw before, and here's a T2 weighted image, and you can kind of see that in this area here, I don't know if you see my cursor, that there's something suspicious here. It certainly looks like an abscess. And once again, in the fat-suppressed T1 weighted image, we see it's rim-enhancing, goes low signal center, and this is diagnosed, and clearly it's an abscess. We see the same thing when we see bone abscesses, when we add contrast. When we're looking at chronic osteomyelitis or subacute osteomyelitis, the low signal area is sclerosis or bone around this abscess. If we were to add contrast to this scenario here, this is bone abscess and this epiphysis, here Brody's abscess, here you see the enhancement tells us for sure that it's fluid-filled, and that's what we're doing on this fat-suppressed T1 weighted image plus GAD. So, question number one, is there data out there that tells us how frequent abscesses are present when we don't suspect them? And the answer is yes. Looking back at Mark Schweitzer and William Morrison out of Philly in 2002, they did a large study, 161 feet, and most of them were 82% plus were diabetics. All these patients' diagnoses were confirmed with bone biopsy for osteomyelitis, and they found that almost 20% of these had occult abscesses, things they weren't looking for. And they're significantly more frequent when you have patients with underlying osteomyelitis or in postoperative scenarios. This is some images from their study, and here you can see on the high, you probably don't need the contrast in order to make the diagnosis of abscess when we look at image on the left versus the right. The image on the left is a water-weighted image, and you can see a discrete focal collection in the midfoot here, or I should say in the distal forefoot, or proximal forefoot, excuse me. And here you see it's rim enhancing over here. But you didn't need the image to make the diagnosis of abscess. Nor would you have it here for this large plantar space abscess. But you see the rim enhancement makes it all that more conspicuous to me. One of the things they did bring out is that we have profound overall inflammatory changes. It is possible for these abscesses to be obscured with T2 weighted images due to edema. Here's an example of some images where can you determine with standard imaging where the abscess is. So look at the center image, and where exactly is the abscess, can you tell? Because there's dramatic swelling and interpatchy edema all over the place. And here you kind of see very clearly where the arrow flies, and here's the abscess over on the dorsal medial side. But I think this is really a minority of cases, is not something we really have to worry about. Most of the time, you don't need gadolinium to diagnose an abscess, all right, but it can be helpful. So let me show you a quick case review. This is a case done where I'm going to tell you everything. Here's an example of a patient that has a heel lesion, okay? Fat-suppressed image plus gadolinium shows a discrete rim-enhancing lesion. And now we look at the fat-suppressed T2 weighted image, and it's also low signal. Now that doesn't make sense, because remember, it should be high signal if it's fluid. Now it's low signal on both of them. So can anyone guess what this is? Must be most likely in this diabetic patient. Most likely a solid foreign body. It's not enhancing either way. So you can tell foreign body very easily by the use of gadolinium in this particular case. Here's a surgical case study. 63-year-old diabetic patient, sub-1 callus, intradigital drainage. Now I'm going to tell you, this is a case where we make an assumption everything is done correctly, and standard MRI scanning is done before the patient's taken to the OR, period. Everything is done correctly, all right? No question about it. So there's positive for abscess, negative for osteomyelitis. Patient's not dysvascular, And you see this case, and when we look at the surgical case progression here, some necrotic tissue here, perhaps, and you see obviously the draining, you have a lot of drainage coming out of this, not looking too good. And the bottom line after all this is that we have disarticulations, multiple, okay? And that happens, all right? And down to good tissue, okay. But this brings up the question of MRI imaging and limb-sparing procedures, and somehow the MRI underperformed here. I mean, clearly, if it had performed properly, in some way, perhaps there would have been an inkling of a patient going in for drainage and winding up having part of the foot amputated. And I'm going to say that perhaps this is where you have to consider gadolinium being added to it. So let's look at this. Let's look at some images adding fat-suppressed gadolinium. These are standard images, and you can see the ulcer over the plantar, midfoot here. I should say distal forefoot here, over the third ray, under the third ray. And here you see it's low signal, and here you see it's high signal. It looks like there's marrow edema involving the toe. And there you go. And so osteomyelitis is the diagnosis. And so now we're going to go and we know it's osteomyelitis. But this is the fat-suppressed image plus gadolinium. And that entire area that was high signal is low signal here. This non-enhancement means that this is necrotic tissue, and it's been misread. So the addition of gadolinium allows you to see necrotic tissue, not just for abscesses, but necrotic tissue. Now you could ask, how often does that happen? Well, in 2002, once again, another study by a parallel study done by Morrison and Schweitzer looked at necrotic tissue as an unexpected encounter when they were looking in a large population of osteomyelitic patients. And once again, you see it's largely the same population, but now what they did is they looked for areas of non-enhancement when they added gadolinium to these studies. And the results were rather impressive because all these animations get in the way when you're the bottom line for all this very busy slide is that if you looked at the signal characteristics, if we didn't have the contrast, only 11% of them would have met the criteria for necrotic tissue. The vast majority of them was standard imaging without contrast, your standard T1, T2, or water-weighted images. So what we see here is that up to 25% of the patients, basically 1 in 4 patients, had areas that were non-enhancing necrotic in nature. And once again, this is probably going to put me over the limit time-wise, waiting for this stuff to stop. But once again, when these areas don't show visible enhancement, generally what you're looking at is necrotic tissue. This is a patient we had seen earlier, ghosting of the bone. We know there's osteomyelitis. Fat-saturated T2-weighted image shows us there's a large ulcer site. But here you see this whole area in here is necrotic on a GAD image in the lower right, fat-suppressed GAD image. And when we look at these are your standard images. All right, if you don't get GAD, you have a 5th ray, cellulitis, deep infection, and once again, the fat-suppressed image, the water-weighted image doesn't tell you that much. And here you see, when we look at the GAD image over here, this whole area of the 5th ray outline is non-enhancing. It's necrotic. And it'd be nice to know that in advance, Once again, if you use the MRI in this way, and we see these areas that are not enhancing where the arrows are, the red turquoise arrow, these are non-enhanced areas, this is necrotic tissue. And I think this is a great value before you take a patient to surgery of doing the MRI and adding GAD, gadolinium, adding contrast. So this does appear to justify the routine use of contrast in those patients, diabetics, who have kidney function. We have to preface everything by saying that if you're a diabetic patient, you have to have kidney function. The litmus test for that is the standard is GFR of 30. It's got to be that or greater. Unless it's, so you could sit there, if it's end-stage renal disease, that's a potential pause. There have been cases of patients who still undergo those studies and are dialyzed afterwards. But once again, I would suggest that you don't routinely say it's a diabetic patient and I don't want to do GAD. So here's the abscess after GAD. We kind of see this rim-enhancing lesion. And all this distal forefoot here is necrotic in this patient. It's nice to know these things in your diabetic patients. Where am I at time-wise? Some of the things you can do with GAD is just bring out fistula, all right? And here's a inflamed toe. Look at the uptake in the soft tissues. And look at this ulcer and this complex fistula formation, which in the next image goes right down to bone. This is what the GAD can do for you, this fabulous imaging. And if I can blow it up this big, obviously, as an imaging modality, it's pretty amazing. So we have osteomyelitis, cellulitis, and once again, the fistula there. And fistulas kind of pop up when you least suspect them. Here's an example of a Charcot foot. Here's our T1 weight. There's nothing but dust up here. I'm probably wasting my time with this whole talk now looking at this, but has anyone able to see anything? Raise your hand. Okay. All right, anyway, so here's your T1 weighted image. And it's obviously ghosting of bones, geographic involvement of the marrow. It's no reticular or subcortical patterns here. And you see here cellulitis, replacement of these fat lobules over here. So we see these things, and when we add our fat suppressed image plus GAD here on the right, you see this fistula, excuse me. Here's a fistula heading down for who knows, and if it's probably heading down for bone. And here you kind of see osteomyelitis of the cuneiforms, and here's an abscess that jumps out. The abscess was really not seen very well on the other shots, but here we see it, once again, it's brought out quite cleanly on our contrast enhanced image, and you see necrosis here of the cuneiform. So all these features would not be visualized without the contrast study in this diabetic patient. That's about it, huh? Okay, let me close this down. Here's just one more case, and time went fast. Ulcer, fistula, abscess. Look at this type of stuff that you see with the fat suppressed image plus GAD, and you can see there's osteomyelitis here too. Let me just quickly get to one more thing here. We just don't have time for a lot of stuff here. Forgive me for flying. I'm going to close this down by looking at this here. So to tie this in with Dr. Shook's talk for last minute or so, this study that was published in 2008 by Mark Schweitzer and Andrea Donovan, one of the things they bring out is the idea of osteitis, which you've heard already is just inflammatory changes of bone, which you see on the T2-weighted image. Of course, the classic definition is really cortical as opposed to osteomyelitis. So one of the things we need to watch out for, once again, is T2-weighted images that don't map, T2-weighted changes, signal changes, that don't seem to map on the T1-weighted images. Here's an example of their article of a patient who's had a distal amputation. You see there's definitely some marrow signal here. And even though it's a T2-weighted image, one would argue that's not really a geographic high signal intensity thing. It looks a little funny. You could argue maybe it's even almost reticulated on this particular pattern, okay? When we look at the T1 weighted image, there's virtually nothing, not even some cortical changes. And so this is what they call osteitis. And I think what the studies by Collins and whatnot are talking about what we're looking at is basically refining the art of looking at the T1 weighted images to a point where we understand osteitis better. Osteitis can be infective or non-infective. It can be secondary to long-standing ulcers, seeing cases of both. And when we have this patient who has absolutely zero, has got an ulcer, but there's no other secondary signs. I mean, we don't see a fistula, we don't see a lot of inflammatory changes. It's one of these chronic indolent ulcers that Benjamin Lipsky talks about. They've been around for a year and a half to two. You know, they're just not getting better. And then you see these signal changes on the cuboid. What do? You've got to, is this one of those 15% of those cases we talked about before? You've got to get to T1 weighted images, and that brings me to Dr. Collins' articles, and we'll call it. Thank you very much.
Next, we'll have Dr. Teresa Carmen come up. She is a vascular medicine specialist from University Hospital Systems in Cleveland, Ohio. And I need to find her lecture. Thank you very much, Dr. Carmen.
Good morning. It's a pleasure to be here, and I was asked to talk about medical management in patients with peripheral arterial disease. So I don't really have anything to disclose for this. We do know that our patients with peripheral arterial disease, medical management is very important in these patients, and PAD and CAD go hand in hand. Unfortunately, when we look at our PAD patients alone, we realize that they are really undermanaged compared to our coronary artery disease patients. So this is a study out of the Kaiser system. They looked at almost 93,000 patients with documented peripheral arterial disease. And you can see that only about 2/3 even had a screening lipid profile. So it's hard to manage medically patients if you don't know where they're standing. About 1/3 were on statins. Of those, the vast majority still had LDLs that were elevated. Of the 25% that had diabetes, more than half were suboptimally managed. And of the patients meeting blood pressure goals, only about half were on medical therapy, 1/3 were on a beta blocker, and about 1/3 on an ACE inhibitor. So not the best management in these patients. This is a even higher risk population. Now, these are patients actually presenting to a vascular surgery clinic. This is from University of Michigan data. So these patients have had identified PAD or CLI, and they're actually being referred for further therapy. So presumably, the primary care doc or endocrinologist, somebody referred them. So 45% still smoking. Only about 70% were on an antiplatelet agent. The rest were started at the primary encounter. Again, 70% meeting current blood pressure guidelines. More than 20% that were not managed according to our current diabetic hemoglobin A1C guidelines. And about 25%, so 1 in 5 had hyperlipidemia that was not being treated. So what guidelines do we have? Well, we've had a series of guidelines over the years. The most recent publication for guidelines comes from the AHA and ACC 2016 guidelines. These were very general guidelines, and I'm going to go through them in a fairly general fashion, but I will give you some other background and data for many of these recommendations. So it is currently recommended as level 1 evidence and a Class A recommendation that all of these platelets or all these patients should be on an antiplatelet agent. That is either aspirin or, in the case of an aspirin allergy, clopidogrel. For the most part, dual antiplatelet therapy really isn't not necessary in these patients per se, although there is some data that it may be helpful to reduce MACE, but not limb events. And then after therapy, certainly the dual antiplatelet, or after interventional therapy, the dual antiplatelet therapy for at least a period of time is warranted. All of these patients should be on a statin medication. And a few years ago, the guidelines suggested that we no longer really need to look at, per se, the HDL and the LDL in these patients, but they all should be on at least moderate to high-dose statins. And there were guidelines surrounding what constituted moderate and high dose. Well, this has been further supported by some recent data that was published in 2017. Now, this is data out of Japan. These were patients who underwent limb revascularization. So again, high-risk patients, they've already had therapy. And you can see in the blue lines, patients who were on high-dose statin compared to low to moderate dose statins, they had an overall reduction in overall survival that was statistically significant. Their major adverse cardiovascular events did not meet statistical significance, but were significantly reduced. There was no difference between the two groups in male or major adverse limb events, and their amputation-free survival, while the curves separated again, were not necessarily statistically significant. But we know that statins in these patients play a role not just in LDL reduction, but there is really pleiotropic effects on the endothelium and benefits relative to these patients, and certainly I think they all should be on at least the equivalent of atorvastatin 40, if not the high dose atorvastatin of 80. Well, what about our blood pressure guidelines? So the goal or the recommendations on a 1A level were that antihypertensive therapy should be administered to patients with hypertension and PAD to reduce the risk of MI, stroke, heart failure, and cardiovascular death. So again, MACE events is what we're targeting here. About a month ago or so, the AHA came out with the latest and greatest blood pressure guidelines. Now, this is clearly a moving target, and if you pay attention to this area of recommendation, about every 3 years our target changes. So our target changed again a month ago, where now our hypertension stage 1 is again defined as a blood pressure of 130 over 90. So all of those patients, our target now is less than 130 over 80 in our patients. If they have that 140 over 90 or higher, which was our target based on JNC7, they're now stage 2 hypertension. So we're backing our targets down once again. All of these patients should initially be managed with what we call lifestyle improvements related to high blood pressure. So advised on weight reduction, a healthy diet, controlling sodium intake, recommendations for physical activity, recommended to stop smoking, and then moderate alcohol consumption. Past that point, the choice of antihypertensive regimens really can be made based on some other disease-specific choices. So clearly in your patients who have diabetes or renal disease, we're really looking at patients wanting to be on a beta blocker, ACE inhibitors, calcium channel blocker, thiazide diuretics, probably second-line therapy in those patients. Patients with other cardiovascular events, the beta blocker ACE inhibitors become our first-line therapy. Well, what about smoking? All of these patients should be advised to stop smoking at every visit, right? So this isn't sort of talk to them once and then let it go. You really should talk to them at every visit. It's clear that until they identify that stop point, they're probably not going to stop, but it's not a harmful thing to keep putting in their head. We don't have enough information yet on the vaping and the other, modalities that are out there now, but I do think it's important that we talk to them. The guidelines go on to say that these patients really should be advised and helped to develop a plan to stop smoking. So again, we have to identify when they want to stop and then help them further. That plan should include pharmacotherapy and or referral to a smoking cessation program. This has become a little bit easier because I'm going to talk about exercise therapy coming up. I'm going to talk briefly. If you were in the session yesterday with Dr. Beckman and Dr. Jaff, you heard very clearly about the role of exercise therapy in these patients. It's now very easy that since we have approved exercise therapy programs, at least in our facility, we couple that with smoking cessation. So you can do all of your risk factor modification in sort of one fell swoop. What about diabetes? I think there's supposed to be a talk on diabetes today, so I'm not going to cover this. Our current hemoglobin A1C targets really should be less than 7. Those are for cardiovascular protection. And this should be a multidisciplinary approach, right? So again, there's no harm in talking to your patients about a diabetic diet. There's no harm in talking to them about good glycemic control and the role that that's going to play in wound healing. However, involvement with your primary care doc, your endocrinologist, certainly is of utmost importance. You heard a lot about your biomarkers today for infection and a lot about your biomarkers today for risk to your patient. One of the things I always ask, in addition to how well are you feeling, what's your blood pressure, what's your pulse, what's the redness look like, what were your sugars this morning? The sugar is also very sensitive. So if they run an AM fasting blood sugar of 150, 160, and it's pretty good, and they tell you this morning my sugar was 300, that's a bad sign, right? They've got a lot of acute phase reactant running around. They've got a lot of inflammation in that setting. Exercise guidelines. This really applies to our patients with claudication, albeit all patients with PAD will benefit from this. Clearly, you can't put your wound patients off on a treadmill and ask them to exercise, right? That's not our goal in these patients necessarily. But the supervised exercise program is designed for our claudic patients with PAD to improve functional status, quality of life, and to reduce leg symptoms. There was a big debate and there's a lot of conversation about the role that plays in addition to revascularization. I look at exercise in these patients as a lifestyle change. We want to get them exercising. Whether or not we send them to revascularization, I want them to do this long term. because those maintenance benefits from a cardiovascular effect, from the effect on their blood pressure, from the effect on their lipid metabolism, and from the effect on their glucose control is a persistent effect, right? Whether or not we send them to revascularization in the long run. A structured community program or home-based exercise protocol to induce that behavioral change really is best. It does seem from multiple studies that those supervised protocols do better for patients. I actually try to get a lot of my patients into silver sneakers, right? That is a really great Medicare benefit that's available to a lot of our patients, and it gets them into those structured protocols and those structured programs. The programs themselves are fairly well defined. We want this to be at a hospital or an outpatient facility that has a rehab component to it. We correlate ours or associate ours with our cardiac rehab because cardiopulmonary rehab is really well established in many centers. Intermittent walking is your treatment of choice. Usually this is 30 to 45-minute sessions. They should be at least 3 times a week. And it includes a warm-up, cool-down period, and the supervised component should be with a qualified healthcare provider. Also in that same program, you heard about the benefits of cilostazol or the potential benefits of cilostazol in your patients with peripheral arterial disease. My experience is similar to Dr. Beckman's. Not everybody benefits from a trial of cilostazol, but in your patients with peripheral arterial disease and claudication, I certainly will give them a trial of cilostazol. If they come back, they feel they're not walking any better at 3 months or 6 months, I will usually take it away because it is relatively expensive in these patients who have polypharmacy. It does add one extra layer of complexity to their care. And if they're not deriving benefit, I would prefer to tailor their drug regimen overall. Pentoxifylline really has not been shown to be a great adjunct in our patients with intermittent claudication, and we don't really use that. Interesting, just as an aside, right? The PAD guidelines did recommend that all of your patients with PAD should have the influenza vaccine. I think that's relatively intuitive. These are usually an older patient population. Most of them have diabetes. These are patients that benefit from the influenza vaccine, but it was a recommended part of the guidelines. They went even a little bit further, and they talked about foot care. This is important, right? It's hard to find a lot of cardiologists in my practice that pay attention to the feet, right? We heard about this morning. Rarely do the shoes come off, and that's a real problem. So shoes need to come off of your diabetic patients. They come off bilaterally at every visit, and you need to encourage your cardiology colleagues to accept that behavior. But the guidelines recommended that counseling about self-foot examination, healthy foot behaviors, early evaluation, diagnosis, and treatment of foot infection, and then participating with your other providers to make sure that your patients are well cared for from a diabetic foot standpoint. So in conclusion, we have these universally applicable, modifiable risk factors for our patients with PAD. So they should be on an antiplatelet agent, statin, blood pressure control, diabetes, smoking cessation. Do I expect you guys to do that? Not necessarily, but it is really easy in your evaluation to identify that, put it in a letter back to the primary care doc and say, hey, by the way, I just noticed the patient's not on a statin. We've got pretty good data that a statin would really be warranted. If there's not a reason not to be, would you think about starting it? In my practice, because I have a big referral practice, and you hate to step on your primary care doc's toes, right? So even though I'm an internist, I hate to step on their toes. What I usually do is I will send that back in the letter. If they come back to me one additional time in follow-up and the statin is still not on board, you're free to do it, in my opinion. Right? You gave them the chance to kind of step in. So I give them the first opportunity to start an ACE inhibitor. I give them the first opportunity to step to the plate with the blood pressure control. And I give them the first opportunity to step in with a statin. I don't hesitate to start an aspirin or Plavix or something else out of my office. I really don't hesitate to do that. Those additional adjuncts of supervised exercise, the use of cilostazol, foot care, influenza vaccine, again, easy to put into a letter. You are certainly also more than capable as healthcare providers to initiate those in my mind. With that, I'll thank you for your attention.
Thank you very much. Dr. Walters is going to come back up and do skin grafting and limb salvage for a few minutes, and then we'll keep moving forward. I'm going to hand out some evaluations. I know that this is kind of a hassle, but it really helps us. We're going to do this again next year, and we want to know what we did well and what we didn't do well. And so if everyone could take just a few minutes and hand out to fill out the evaluation form, it would be much appreciated.
So a lot of you have probably seen diagrams like these before. When we take a split thickness skin graft, generally we want to shoot for somewhere mid-dermis. That allows us to get the full thickness of the epidermis, as well as some of the vascular structures of the dermal layer. Now, when we apply a skin graft to a wound, it heals in 3 phases. First is a plasmatic imbibition. This is where basically the skin graft is drinking the fluids off of the wound bed. And then following that is inosculation, where the blood vessels start to approach the new graft. And then after that is revascularization, where the blood vessels have completely anastomosed to the new graft, supplying new blood flow. So the plasmatic inhibition usually occupies about the first 24 to 48 hours, followed by inosculation, which is somewhere between the first 48 to 7 days, with revascularization occurring over the course of several days to weeks. Now, when we place a skin graft, the crucial part of that healing phase is this plasmatic imbibition. And anything that inhibits that is going to inhibit the take of our graft. This can include things like a hematoma, a seroma, shear forces where the graft itself is being slid along the wound bed, and then infection, where the bacteria, or in rare cases fungus, separates that graft from the wound bed itself. Now, split thickness skin grafting is an excellent modality for covering these wounds because it provides several different benefits. First and foremost is it's a rapid form of closure. We can just graft it, and then the wound essentially is gone. As soon as it heals, we don't have a wound anymore. This allows patients earlier return to function, it reduces their risk of infections, reduces their fluid loss and protein loss, and reduces chronic inflammation. And there's several studies that have shown that these can be effective in diabetic patients. Patients who would be a good candidate for skin grafting, in this case, are patients who have stalled wounds, who have large wounds, who have a healthy wound bed and good granulation. This is generally pretty much every patient that we see with a wound. However, before they get to that point, they may have some moderate heavy drainage, moderate heavy necrotic or fibrotic debris, bacterial burden, inadequate blood supply, and excess bone. All of these issues need to be addressed before we go ahead and start with the grafting process. Now, generally, when we see a wound like this, we want it to proceed to this, but there's a lot of factors that go on in between. So Tan Din in her lab, they looked at the factors that affect the diabetics in particular. And they did a large retrospective analysis back in 2012 to identify what's special about the diabetic patient. What's interesting is they did find that these patients had these studies all had a pretty high rate of success, somewhere between 65 and 94%. Success being defined as a 90% epithelialization at about 4 weeks. So what they found was these 4 factors: nutritional status, offloading, vascular status, and infection. Nothing is new or exciting about this. This is pretty standard information for anybody getting a skin graft. There's a couple of things that I think that we need to add to this figure, though, as far as managing our diabetic patients. So we've already talked about the benefits of debridement, removing bioburden, biofilm, chronic inflammatory factors, and converting these wounds to acute wounds. Furthermore, John Lewis's lab did a retrospective analysis looking at the effect of bacteria within these wounds. What they found was that 91% healed within 8 weeks, despite the presence of bacteria. But when they did their subgroup analysis, they found that Staph aureus and Pseudomonas did significantly reduce the take. But what I think is interesting is this other group over here, the other bacteria, which didn't significantly reduce the take or the success of these skin grafts. So we did a similar study retrospectively at Georgetown, looking at what makes skin grafts successful or unsuccessful. When we do a skin graft, we always debride these wounds immediately prior to placing the graft. And prior to doing that debridement, we do an initial wound swab, followed by debridement and a post-debridement wound swab. So when we looked at these swabs, we found that those who had growth versus those who had no growth, it made no difference in the success of that at any time point, whether it was 30 days, 60 days, even out to a year. There was no significant difference in healing. Furthermore, when we looked at whether or not they had growth at the pre-debridement swab or the post-debridement swab, again, it didn't make any difference in healing these wounds. What we did find, though, was that venous stasis and congestive heart failure had a very large impact in the success of these skin grafts. And I think that that just goes back to our last lecture on the importance of managing these patients' comorbidities. It's not just about managing the wound and getting the foot adequately supplied. It's about getting regular debridement and comorbidity management on top of all of these standard surgical practices. So overall, skin grafting is a very effective method to close these wounds. It's quick, it's easy, and it can be done virtually anywhere. It doesn't require perfect sterility. You can graft these patients even if there is a positive culture. It just needs to be non-clinically infected. But it does require some comorbidity management and effective treatment. Thanks.
Our next speaker is the Dr. Nehru Shibuya, who I believe has come all the way from Texas. And he'll be talking to us about how the role of deconditioning how it can play a role in our surgical patients. Dr. Shibuya.
Good morning. Yes, I did come from Texas, and I like talking at the limb salvage conferences, but I kind of show you the different way of looking at things. We talk about reconstruction and limb salvage all the time. Well, since this is my first talk, I just want to go through the disclosure. My view does not represent Texas A&M University, U.S. government, or Baylor Scott White healthcare system. I'm consultant for those companies, but those are all orthopedic implant companies, and that's my disclosure. So when the athletes get injured, what happens? Well, athletes, those are young guys, and we're talking about all the high-risk patients, but when the young guys gets injured, sometime during the course of a season, they get deconditioned. Every day they're off the court, they get deconditioned. It's hard to get back more you stay off the court. But these guys are young guys, of course, so they could get back very easily with a lot of conditioning exercises. They have no problem. But when we're talking about our patients that we talk about in the limb salvage conferences, you're talking about these type of patients. We naturally decline the condition every day, regardless of what kind of a treatment we're doing for these patients. Myself, deconditioned, last 5 years, I used to be able to run a mile, and nowadays, I could hardly walk a mile. But on these patients, surgery or hospitalization, we do a lot of reconstructive surgery, Charcot reconstruction, taking those patients to the OR for a very long time. That deconditioning is very significant. And unlike those 20, 30-year-old athletes, we cannot get back to recovery most of the time and stays down there. So when you're talking about the patient like this is a patient, 52-year-old female with Charcot who had no kidney disease, but she has a depression. She uses a walker and she doesn't work, and she has a previous reconstruction by different surgeons, and she had multiple visits to the hospitals and clinic and being in wound care and all the stuff. And is it worth doing a reconstruction for this type of patients? Because when we talk about hip fractures, there are a lot of evidence out there, and we talk about it all the time. And a lot of times we have a similar characteristic of patients we are dealing with. And the hip fractures, the 1/3 of patients never go back to the independence, and 50% needs long-term care, and 25% require full-time nursing care. And the deconditioning is defined by functional decline, like loss of balance and muscle atrophy and weaknesses, but also talking about cardiovascular decline as well. And the deconditioning has been studied a lot in the sense of a hospital admission and major surgery, cardiovascular surgeries, not so much in the foot and ankle surgeries, but they have found a lot of risk factors that are associated with the post-admission or post-surgery deconditioning. And these are the risk factors: age, mental health status, prior hospital stay, pre-admission condition, and iatrogenic effect on the treatment. They all result in the deconditioning or nursing home stay and hospital stay, and all those factors are increased in those patients. As far as age goes, if you're 65 years or older, and almost 50% of those patients who are admitted to the hospital, after discharge, they develop a dependency. That's a very high rate of dependency after the admission. And when you're talking about someone even higher, 75 or 85-year-old, they're twice or 4 times as likely to develop the dependency after admission or a major reconstructive surgery. So we have to certainly look at the age before you're considering a major reconstructive surgery and limb salvage procedures for those patients. And the mental health is very similar. Deconditioning is proportional to the mental illness. If the patient has a mental illness, obviously those people are harder to get back to the condition. And the mental health status is really dependent on a lot of factors. And you could get a lot of this from the social history, the exercise, and having the family and having the friends around is really positive effect on the mental health status. On the other hand, trauma or depression, multiple admission to the hospital and going to the wound care every week, those things negatively affect mental health. So how to judge patients' mental health? Well, you could ask those questions. Do you have a good family support at home? Do you have friends? Those kind of questions, a lot of times we forget when we try to see a lot of patients every day, but we have to spend a lot of time on the social economic status of the patients to kind of judge the mental health status of these patients. Also, those are associated factors on the mental health status, but you really have to look at the cognitive function of those patients. And there's, instruments to measure that. We all learn in the medical schools and such. You're supposed to ask the patient, these simple questions, which ear this is and all that stuff. And you could use the instrument to kind of quantify it, but a lot of times you don't spend that much time on it, very much talk to the patient, try to get the sense of it from multiple visits to the office. But a lot of times what happens is, a lot of times when we try to see these patients and looking at these patients, you're considering the limb salvage or major reconstructive surgeries, I find myself talking to his or her husband or wife, because usually husband or wife has a better mental status, and the patient is more high risk, and the partner is usually in a better shape, and start talking to the patient's wife, and then you kind of neglect the patient himself. So you're not really assessing the mental health status on the patient. And a lot of times you have to be careful with those people who are overly understandable, the patient who agrees to everything that you mentioned, or overly acceptive patients, because a lot of times when you look at those quality of life on those patients, they're not really good measure to understand the patient's overall status, because a lot of people with the underlying mental health status, mental illness, a lot of times because of the neuropathy and diabetic neuropathic patients, they also has a physical brain damage resulting in the mental illness. For those patients, the quality of life is really not a good measure to assess the overall status of the patients. And a lot of times we use the instruments like SF-36 and mental health status. You ask the general question like, are you nervous? Are you peaceful? And all those general questions. But again, these are not really sensitive enough to detect the status of the patients. And this study compares those people who had a foot problem and the people who didn't have a foot problem, and look at all those factors, and they found all those factors are worse in those people who had a foot problem, but the mental health section of the SF-36 was not really different. So again, that quality of life measure is not a really good sensitive instrument to judge those patients. Pre-admission conditions. Again, this comes from the social history part of your seeing the patient. Is the patient able to do a lot of the daily activities or instrumental activity of daily living? How many times you ask the patients and what kind of medication you're taking, how many Neurontin you're taking at night, and a lot of people don't know. They just follow what's in the bottle every time. So a lot of those patients are lacking the activity of daily living, and those people are more likely to have deconditioning after admission or after major reconstructive surgeries. If you use those instrumentation, you can actually calculate the risk for declining in activity of daily living after admission or the reconstructive procedures. What about assistant device? People walking with the crutches or the walker or even the wheelchair. It is shown in the study that those people who have assistant devices, they're almost twice as likely to develop the deconditioning or independence after the discharge from the hospital or major reconstruction. Self-reported unsteadiness, a lot of times we call it the full risk. If those patient has a full risk, again, that the chance of getting the deconditioning after the major surgeries like limb salvage procedures, patients are twice to 3 times as likely to get the deconditioning. So go back to this patient that I showed you, the 52-year-old diabetic female with Charcot. She has a depression and pain and previous reconstruction. She got a previous admission for that purpose and for the infection purpose, and she uses a walker all the time. So if you look at all those risk factors that I talked about, age-wise, 52 is not too bad, but if you look at the mental health, she already has a depression. She has a severe neuropathy, so most likely that goes to the brain as well at this point. And the previous reconstruction, meaning prior hospital stays, and she uses a walker. She already uses an ambulatory assistant device. So you know that the odds are against as far as the deconditioning goes. And in fact, this was a long time ago, more than 10 years ago that I did this procedure, and it actually did very well. If you look at the MIFA, like you have a solid bone fusion. It looks so nice that I actually used it for my chapter in the Charcot book. But the result was that I didn't write on the chapter was that the patient is dependent on the husband for traveling and many activity of daily livings. And since the surgery, she has multiple hospital visits. She's still alive, but she's in and out of a wheelchair and occasional wound here and there. So is that considered a success or successful limb salvage for this patient? I'm not going to answer the question, but something we have to think about. So she has a lot of nursing assistance and hospital stays, and mortality goes up and readmission goes up on those patients. On the other hand, this is a 55-year-old diabetic male with Charcot. You could see that the ankle joint is kind of shut. It's going to varus deformity. The wound is in the lateral column of the foot. He does have a good social life. He's a veteran, and there's a big Army, the Fort Hood in Central Texas. So there are a lot of the veterans live in the area. So he still has a lot of friends and good social networking going on there. And his wife is a nurse, and she's very intelligent, and obviously he has a good assistant at home. And he has no history of admission. This is the first time he had some kind of complications. Even though he has a neuropathy up to the knee, he is still in a good condition medically, and he was placed in a wheelchair by me, but he was recently placed in a wheelchair. So he was not really dependent on assistant device until this time. So for this patient, again, age is good, and mental health is still good socially, and he has a good family, and he doesn't have too much prior hospital stay or the clinic visits, and again, the wheelchair is just for this condition, not for dependency from the prior problems. So for this patient, odds are very good, so I went ahead and did the reconstructive surgery, TTC fusion, and radiographically, it's good, but also he's still independent. He could do most of the stuff by himself without the family help. He has no further hospital visits so far after probably 3 years now, and he's still alive, and he ambulates with the AFO without assisting devices like crutches or a walker. So when we're talking about deconditioning, again, that the natural progression is already declining, and the surgery and hospitalization, sometimes we can avoid it, but a lot of times we have choice in what to do for the patient. Does the patient has to go through the major reconstructive surgery, or we could get away with just minor amputations? We have to think about it, because you will have to really limit the decline of deconditioning in those patients, so the patient has still a chance of recovery to the baseline, rather than just staying underneath. And in order to find out who's going to do well or who doesn't do well, you really have to know these risk factors that I talked about. Thank you.
Our next speaker is going to be Dr. Jordan Botek from Cleveland Clinic. I believe you should see Martin over there. And anytime it's a fellow Cleveland, we love to have him at the podium. And she's going to be talking to us about negative pressure wound therapy in salvage vision.
Okay. Well, nothing excites me more about wound care than negative pressure wound therapy. Number one, there's a lot of robust evidence to back it up. Number two, I see the effectiveness in my own patient groups, inpatients as well as outpatients, diabetics and non-diabetics. And thirdly, they're so innovative. Every 6 to 12 months, I'm finding about a new product, a new way or technique to apply it, new indications to use it. So for me, this is one of the more exciting topics to talk about in wound care. If we just take a second and look at the progression and evolution of negative pressure wound therapy, it was first described by a German traumatologist in 1993. And then it later moved into basically all usage with wound care, skin grafts, flaps, delayed closures, and bioengineered advanced tissue products. And then we see in 2010, it actually becomes part of the paradigm, the ladder for skin application with the plastic surgery group. And then in the Cochrane review, they look at 5 studies over 600 patients, 2 of which are focused on diabetic foot wounds, and see that there's some preliminary evidence that would indicate that it does heal wounds more quickly. And now with novel therapies, and that's kind of what I want to focus on in our own patient group here, and with keeping in mind this dysvascular patient, how can we work in negative pressure wound therapy? Is it contraindicated? Are the indications to use it? So if we first look at the 2 hallmark studies looked at with the Cochrane review, we see that after partial foot amputations in a randomized study, that 56% healed with negative pressure wound therapy versus 39%. And this is actually more of a bridge treatment, getting to the final closure or final surgical procedure. And then Bloom and the Yale group looked at the safety as well as efficacy of negative pressure wound therapy and found similar results: increased granulation tissue and decreased area of ulcer healing. Negative pressure wound therapy from in vivo, in vitro studies, what we know is that it does increase the rate of granulation tissue, it decreases the peri-wound edema, it prepares our wound bed for surgical closure, skin graft or flap, and decreases the time to wound closure. Less frequent dressing changes. And I also wonder, in looking at Dr. Walter's study, if those skin grafts had negative pressure wound therapy with it, if it had some effect with culture results. It didn't really matter if there was a high bacterial burden or not if we have negative pressure wound therapy with those skin grafts. Economic advantages, while it may seem expensive, if we can decrease length of stay, if we decrease our trips to the OR and increase our wound healing capability, we have economic advantages, and that has been proven over time in different specialties. So going back to some of my first usages of negative pressure wound therapy, had a patient come into the outpatient clinic, 60-year-old farmer, diabetes, neuropathy, some element of vasculopathy, and septic arthritis. So he's certainly admitted to the hospital and a partial first-ray amputation is performed. With visible bone and loss of soft tissue coverage, we put a bilayered bovine collagen dressing on in combination with negative pressure wound therapy. And sure enough, 1 to 2 weeks, it's looking good, and you can appreciate decreased edema, decreased erythema, a clean wound, the silicone layer now sloughing off, and we have another wound that's prepared for advanced bioengineered tissue products to closure. So what we know in the setting of grafting with negative pressure wound therapy, it provides that constant pressure, minimizing hematoma and seroma formation. It maximizes that graft take. It's an excellent dressing for these grafts. It avoids contamination and infection. It promotes neovascularization, and it shortens time to incorporation of our graft. It's a win-win for surgeon and patient. But looking at that case, I think I may do something differently now in 2018. I may employ at some point in that wound healing process this mechanically powered device. So rather than an electrically powered device with a large canister, this is ultra portable, it's disposable, it's changed every 5 days, it's less expensive because we're not needing home health care. We're not needing all the supplies that are involved. So through Medicare and private insurers, we're actually saving thousands of dollars potentially over the course of a wound. It allows our patients to be ambulatory, which is another big plus. And it has proven similarly effective as the electric-powered negative pressure therapies device. And we'll look at this study. So it was a comparative effectiveness of the mechanically and the electrically powered negative pressure wound therapy device, multi-center randomized controlled trial. The primary endpoints were looking at analysis of these wounds at 4, 8, 12, and 16 weeks, and there was no difference in wound healing were shown. They were equally effective. There was no difference in pain, and probably perhaps, the most important part, patients preferred it. They get sick of the negative pressure wound therapy for an extended period of time, and it decreased the application time, which is great for me and my nurses in my clinic if we can go from an 18-minute dressing change down to a 10-minute dressing change. If we look at this case in a dysvascular limb, how can we employ negative pressure wound therapy with a dysvascular limb? Well, this was a 70-year-old Hispanic male who came, first presented to an outside hospital, had these PVRs or non-invasive testing done with a TBI of 0.18. He was told by the group that he should go home and let this toe auto amputate. So when he presented to my clinic January 8th, I wasn't so convinced of this, but I do have a disclosure here. It was actually his right second toe, not the left second toe. I just couldn't find the picture, or maybe I didn't have it from January 8th. So we referred him to over to vascular surgery, and they performed an angioplasty. That was January 11th. So now we're on a second hospitalization, and we amputate those toes 2 and 3. By February 2nd, he came back with the picture that you see here with a necrotic hallux and a necrotic fourth toe. So definitely an ominous sign. Once again, consult our vascular colleagues. They perform a second angioplasty and then the transmetatarsal amputation that you see. What I've been doing on a lot of my partial foot amputations is employing incisional wound vacs. Whether right or wrong, I'm really not sure yet what the indications are or if there are decreased dehiscence rates with them, but it's something that we've been exploring. This is another patient who, it's an example of the application of the negative pressure wound therapy, the customizable sort, and she had effective healing of her TMA. Not so much though with our Hispanic male, where we see in February, remember his surgery is February 7th, I believe, we see some dehiscence of the wound, a soupy wound, And we're not sure how this is going to pan out in February. But we culture, do deep cultures. He's on dialysis. He has antibiotics at dialysis. By March, we're converting that soupy wound to a more necrotically appearing wound, but we're debriding it and doing Dakins. Lots of Dakins on this guy. And his daughter is a gem. She does these dressing changes mainly on her own. By April, we do see some progression, or at least change. We're seeing changing of the wound, which I think is a good sign. It's not progressively getting necrotic, but it's changing. But still, at this point, we would normally see most of our TMAs healed and perhaps even ambulatory by April. But that's not so much the case until we see this in April 24th. And we're actually now thinking, okay, we're on third base heading home. But I also feel like we're working against the clock. And a lot of these patients who had revascularization, how long do we have for the angioplasties to hold up? Is it going to be weeks? Is it going to be months? So we want to get our wounds healed as quickly as possible, especially in the dysvascular foot. And we can see employing mechanical negative pressure wound therapy at this point, about 8 to 10 weeks out, and about 2 to 3 weeks of usage. We arrive at this at May 24th, and we're doing the happy dance. This guy's going to be home free. He's going to heal his TMA, which makes him really happy, as well as his daughter and myself, and we have him in June. If we look at a similar case, this is a 70-year-old Caucasian male who presented with a blister to the lateral foot, which I feel is an ominous sign. Whenever you see that necrotic, blistery look to the lateral aspect of the foot, this is an ischemic wound, it's an arterial wound. And certainly that did prove to be the case, where his TBI here is 0.20. He had already had a left transtibular amputation and a prior second toe amputation on the current side. So the last thing that this fellow wants to hear is that he's going to need another amputation potentially. We refer him to our interventional radiology colleagues, and they do angioplasty, a successful recanalization of the AT, and we can see the difference from pre-angioplasty to post-angioplasty. And with this photograph demonstrating also the hyperemia at the side of the blister, or really truly ulceration site at this point. But a month goes by, and the wound now shows osteomyelitis on x-ray. He's got lysis to the lateral border of the fifth metatarsal head, positive probe to bone, clinically infected, radiographically infected, and we had a consult, partial fifth ring amputation, transmetatarsal amputation. Let's do something definitive in this gentleman. He does not want to hear anything about amputation, so we compromise. We take out his fifth metatarsal head, and I don't want to close it because I'm not sure infection's eradicated, and now we have a deep wound into someone who's dysvascular and not the best candidate, multiple comorbidities, as you saw. So at this point, we do initiate mechanical negative pressure wound therapy once again to see if maybe we can get this guy to the point where I can close him. And sure enough, after 2 applications, we're able to lead to delayed primary close him, and here he is in May. So another success story, which I feel really was helped by mechanical negative pressure wound therapy that's portable, lightweight, and seemingly quite effective. Moving on to our inpatient setting, though, here's a wound that maybe a newer novel therapy could be most effective. So we have a heel wound, and similar to some of Dr. Shook's cases, a recurrent chronic heel wound that now has had 1 OR debridement, as you can see. And we're going to apply some installation therapy to this wound. Now, the idea of cleansing a wound is not new or novel to negative pressure wound therapy. Certainly, this goes back over 100 years into World War I, where Alexis Carroll, a vascular surgeon, would employ this on wounds. Cleansing the wound and debriding wounds are the cornerstone to wound care, and that's what we're accomplishing with a therapy like this. We're cleansing and then hopefully debriding, or helping our debridement with negative pressure wound therapy. I find that this application is good for our inpatient care, and also a few select skilled nursing facilities that have been trained on it. It's good when we know we're dealing with infection, even if it's delaying getting that patient to the operating room, or we're delayed getting that patient to the operating room, we can employ it, or we know we're going to need serial debridements, we can use it. It's also good for our sizable wounds. And there are patients that we can't take to the OR. So I'll start this sometimes in the ICU if I know I'm unable to take a medically unstable patient to the operating room. If we look at the data, retrospective chart review, 142 wounds. In green, we see the negative pressure wound therapy with installation time. Okay, just 2 different time settings, 6 minutes versus 20 minutes. And we can see on all accounts that the installation therapy compared to standard negative pressure wound therapy decreased length of stay, it decreased the time to our final surgical procedure, and it decreased the number of trips to the operating room. So after evidence like this, pretty much this has become our new standard of care in the inpatient setting. If we look also at the application of negative pressure wound therapy with installation therapy for osteomyelitis, we can look at this study that retrospectively evaluated after trauma and debridement of osteomyelitis from the pelvis distally, the control that had your standard debridements, gentamicin implantation beads, versus negative pressure wound therapy with installation. What we've learned over the last few years, again, which is great because this is evolving and innovations, really saline has kind of taken over a lot of these other substitutes for the type of solution we're instilling. But in this case, we can see that, again, favorable results. If we look at this in a bar graph form, you can see the major differences of the rate of recurrence of infection, 10% versus over 50%, and the length of stay, nearly cut in half by the application of installation therapy in the treatment of osteomyelitis with surgery postoperatively. So this is a patient that we're going to definitely consider this on. Very unhealthy patient with congestive heart failure, end-stage renal disease, an ejection fraction of like 14%, who's already undergone prior surgeries. So at the time at bedside, I'm going to put on the installation therapy for him. And unfortunately, we do have to take him back to the operating room, but this is what we'll do. And in this case, it was kind of complicated and something I hadn't tried, but you can bridge it. You can have two wounds and you can bridge them together so that you're instilling both. And then we end up with an ulceration kind of like this, which is now going to be outpatient and managed with standard negative pressure wound therapy. But I will keep him on installation with a wound like this if he's still in the hospital. So again, as mentioned earlier, we have this waffle comb, this reticulated open cell foam dressing with through holes that, the verdict is yet to be out. But this is going to be indicated in a wound like we saw here, and it will assist with wound cleansing by removing thick exudative and infectious materials potentially. The mechanism of action is supposedly this macro strain on the wound, micro strain at work at the edges of the actual foam dressing, and in conjunction with coverage and the ability to become less hydrophobic, more absorptive, allowing more distribution of the instilled fluid. So it can be used on the most large, most complicated wounds, longer dwell times with this type of foam product, and it is not necessarily indicated for clean wounds or small wounds, but we'll see how this evolves in the usage in our practice. So in conclusion, negative pressure wound therapy can help you at all stages of wound healing and probably with nearly all wounds. It is our workhorse in the inpatient setting with the highly exudative wound, the infected wound. It becomes our workhorse. It becomes our bridge to final closure, final surgical procedure, which can help later in the wounds as well. Thank you.
To finish before the established lunch break, we have Dr. Shigui who's going to talk to us about his TMA, the most functional amputation. There's going to be a residence presentation session during lunch, and we would hope that you'd all be here. It's a competition for a prize also. I don't know if Dr. Shigui was talking about that, but we appreciate all of you to be here as many as possible. Thanks.
Cool. All right. So I don't know, in school or residency or fellowship, I was told that the TMA is the way to go. I guess my talk is that true? Is there any evidence to support it? So if you look at the functional study after TMA, so this study looked at different types of prosthesis, shoes and inserts, and see if any of them is better. And the best way to kind of accommodate the TMA patient is to use the full-length shoe, total contact insert, or what we call filler, and rocker bottom shoe. And you don't really need an AFO. But when you compare with the contralateral side where we didn't have an amputation, the difference is just very minimal. There's more pressure on the TMA side, but the difference is minimal. Again, this is another study that looking at the 9 healthy amputees, not the high-risk patients we were talking about, but the difference between the control group where didn't have an amputation versus people who had an amputation. As long as you have good inserts and shoes and they do okay, not much difference between the non-amputated side. The ankle joint range of motion is very similar. Control group is dotted line, and that walking with the partial foot prosthesis is a solid line, and there's no significant difference in those two groups. But the question is it really better than any other amputations? We know that the TMA does okay, but what about those people who had, very weird-looking couple toe missing type of foot, or partial ray amputation, or multiple partial ray amputation? Are they really worse than a TMA? That's, TMA, I was taught verbally from attendings, or teachers from school that TMA is functionally better. So do we really have to do this for this kind of patient, or can we just leave it like that and have a good result as well? Because general belief is that TMA is more functional, less stress to the body, less likely to result in the re-amputation, and easier to fit in the prosthesis. There's some financial background in this country, however. If you look at the two most common amputation in this country is transmetatarsal amputation and below knee amputation. Why is that? Well, if you look at the RVU chart, you could see that the BK and transmetatarsal amputation pays more than anything in between, or toe amputation. So is there any financial interest to American surgeons in this country? But the general belief is TMA is more stable, and a lot of it is because of it is balanced very well. And if you have a TMA rather than the Lisfranc's amputations, you preserve peroneal tendons. So you get the inverted and everter still intact because of the first and fifth metatarsal bases still intact. So people think that that would be more stable than the Lisfranc's amputation. And of course, if you compare with short parts amputation, there's no attachment at all except for the Achilles tendon. And of course, Symes have no attachment. So that's one of the reasons why people generally think that the TMA is better than any kind of any other amputations past the TMA level. But is it really true? So this is a study looking at the ankle power, so the push-off strength, if you will, when you're comparing the toe amputation versus those people who had a TMA versus the people who had a short parts amputation. The little gray curve, wide gray area is the normal control, and those solid lines are the amputees. And if you look at these data, that toe amputation is very close to the normal foot without amputation. But when you get to the TMA and short parts, the difference is not really significant. So in this study, in the conclusion, and I agree that if the patient, once they lose the metatarsal heads, the ankle power loses anyways, and that the ankle range of motion and the power doesn't differ too much beyond the TMA level. This is an interesting study. They actually found those healthy kids who were born with no forefoot. And as long as they had a good prosthesis and they adapt to that, well, that's what they're born with. And they followed those patients for 18 years, and they found that there's no significant difference in the velocity and the cadence and all the other stuff compared to those kids in the same class. So again, that having the forefoot, short parts versus TMA, that kind of shows you that if the patient is able to rehab or have a good prosthesis, the function is not really significantly different. So past TMA up to BKA, the push-off ankle power is about the same, walking speed is the same, and adaptive hip motion is about the same. What about cardiopulmonary reserve? Again, the general belief is that if you lose more volume, you're going to stress more heart and lungs. It's coming from the Pinter study back in 1992. He concluded that the more proximal amputation is bad because you lose volume and you will have more oxygen demand. But his own study, if you put it in the graph like this, you could see that there's no significant difference between midfoot amputation versus Symes amputation versus BKA. As far as the energy expenditure goes, the midfoot amputation is actually worse than the BKA. So it's contrary to what they concluded in the paper. The data actually suggests that there's no significant difference in oxygen demand. But this was a really small study in the 5 patients in each group of amputation. There's bigger study. This is a study on pediatric amputation. So you're kind of negating all those confounders associated with the postoperative recovery and all the stuff. When you negate all that stuff, again, Symes versus more proximal below-the-knee amputation, energy expenditure, energy cost is really the same, unless you go on to the AK. That's a different animal. If once you lose the knee, you're going to have a lot of cardiopulmonary problems. Another study, there are so many studies out there comparing the partial foot amputation versus the below-the-knee amputation. Again, the energy consumption or oxygen consumption is not really different. And if you go back to the older studies, similar results. If you look at the energy cost, Symes versus BK, again, there is no significant difference. And again, if you go to AK, you do lose a lot of cardiopulmonary reserve. This was the study. I was on the back of the room. I was just finished analyzing this data, but we are actually comparing those people who had a TMA versus BKA. This is coming from the NSQIP, or National Surgical Improvement Quality Improvement Program, and we had about 50,000 patients looking at the short-term complication between transmetatarsal amputation versus BKA, and the reamputation rate and readmission rate and wound complication rate wasn't significantly different between those two groups after adjusting for all the other comorbidities with the regression. And the one thing we found out was that if you had a TMA, you're almost 3 times as likely to have within 30 days incision and drainage. So it's actually more risky to do the transmetatarsal amputation. It's kind of understandable because a lot of times we try to do the limb salvage, try to salvage as much as we can, but that's going to result in more complication within 30 days. A lot of times it's planned, but that's what we saw in the data that I just analyzed this morning. What about reamputation rate? So someone mentioned Ruckus data on the partial first ray resection this morning, and this is a systematic review, and they capture 435 ray amputations, and the reamputation rate in this cohort that they capture was 20%. It's a very high number of reamputation rates, so that the general belief, again, is to do the TMA to get rid of all the other lesser metatarsals and make it nice and square and looks like a nice flat the club, that there's no bony prominences, so that the amputation rate can be reduced by doing the transmetatarsal amputation. So I was wondering about this data, so that's why we did the exactly same type of study. So very similar, purposely made a similar protocol to the Ruckus study. And we did everything the same except for we look at the transmetatarsal amputation. So same methodology and a case cross-sectional cohort clinical trials only. Data has to have a reamputation rate, and anything less than 10 cases are excluded. We did the systematic review and the quantitative analysis, and what we found out was that the amputation rate was actually 30% with a transmetatarsal amputation. So using the same methodology, of course, that the cohort is coming from different sources, but if you're just looking at the general overall reamputation rate of TMA compared to the first ray, it's actually reamputation rate is higher with the transmetatarsal amputation and than the first metatarsal amputation. Of course, you can make the conclusion that the TMA is worse than the first metatarsal amputation because different patients and didn't adjust for any comorbidities, but it doesn't really show that the TMA is any better than the first metatarsal amputation. This is just a small study in the workers' comp patients, and very subjective outcome on the digital versus MPJ versus TMA versus Lisfranc's amputation versus short parts, and they found that the Lisfranc's short part amputation was actually better than the transmetatarsal amputation. Just another small evidence that the TMA is not the best functional amputation compared to other amputations. So again, this doesn't apply to everyone, but this is one of the good example that the patient had. A 54-year-old Hispanic male had the fourth and fifth ray resection. At this point, a lot of people go on to the transmetatarsal amputation, but with a good prosthesis, good filler, good follow-up, and patient actually is now 8 years, actually 9 years at this point, and patient has no recurrent ulceration. He's doing actually okay with this. 67-year-old African-American male who had a multiple toe amputation. A lot of times, if you see this, a lot of people say transmetatarsal amputation. Again, the rate of re-amputation with transmetatarsal amputation is not as small as people think, so I just tend to keep these toes on, because again, once you lose the metatarsal heads, that gait is suffered, so I tend to leave these on. Of course, you're in the risk of getting re-amputation, but again, transmetatarsal amputation re-amputation rate is not as low as you'd think. So how do you determine amputation level? We only talk about functional outcome and the re-amputation today, but you also have to consider healing potential. There's, sometimes there's just no option but to do the transmetatarsal amputation. And of course, the patient's preference and the religious beliefs and overall health and rehab potential, they also have to be considered. So is transmetatarsal amputation more functional than other foot amputation or BKA? Or if you look at those data, that statement is not really true. Does TMA provide less complication than other foot amputation or BKA? We look at the re-amputation rate, again, that statement is not true. Is TMA more definitive? Again, the re-amputation rate is not as low as we think, and that statement is not true either. Thank you.